folks. I think a lot of you know me. I feel like this is a group that has come to conference lots of times. So I'm Mary Peterson. I am a CTRS at a little tiny hospital in Sharon, Connecticut. It's a very psych unit. So our patients are acute patients, ages 55 and up. I was telling the other group my oldest patient was 104, and I just recently found out he is still with us, and he just turned 105. Yes, and he's doing fabulously, which actually just gives me a lot of joy. So I thought today that we would spend about an hour or so talking about schizoaffective disorder. It's a disorder that we can see across all of our agencies, but before I really jump in, I just want to go around the room. You can just share with me where you are working, what agencies you're with, or what kind of populations you're with. That way I make sure that I kind of hit all those points.
I'm working with Northeastern Association of Blind in Albany as a clinical specialist. And obviously it's working with blind visual impairments, but with losing your vision comes a lot of psychiatric issues.
Yeah, lots of sensory related concerns.
Yeah.
Awesome. Cool.
Work at a local hospital. Inpatient behavioral health unit. Huge adult.
Whereabouts in New York?
I'm not in New York, in New Jersey.
Oh, no, welcome. Thank you for being here.
I work at a psychiatric hospital, and I'm on the adult unit.
Shane, I work for the Office of Mental Health in New York State, from Psychiatric Center. Supervisor rehab service.
Rehab services.
Albany Medical Center.
Oh, we got chat. Just adults.
Yeah.
And I'm Robin, and I work with adults.
Okay, awesome. So this is a great crew because I think we kind of hit the spectrum of lots of different agencies, lots of different populations. This is great. So I am no means an expert in schizoaffective disorder. It's just something that I see a lot, and I see in my patient population and my staff that go, I get this, but I don't really get this. What is this thing? So please, we are all together. Let's use our knowledge and share. So if you have insights, please, there's not a lot of us, so shout it out and let's chat. My slide advancer broke this morning, so we're gonna have to go old school. I'm sorry. So today we're going to cover a couple of different topics. We'll do definitions, history. We'll talk specific characteristics of this disorder, as well as then we're going to jump pretty nitty gritty into considerations for treatment and facilitation techniques and interventions. This is a pretty heavy topic for the end of the day, so I'm really sorry. But if you need to get up and walk around, do whatever you got to do, just let me know. Okay. So we're going to start with a very basic definition. I like to really go right to, I believe this is Merriam-Webster. So schizo comes from the Greek schiza, or split piece of wood, so literally a split. And then we have affective, to produce an emotional response. So when you combine those two things, you get schizoaffective disorder. A mental health disorder that is characterized by having elements of both schizophrenia and mood symptoms. It's both together. So in order to really understand schizoaffective disorder, we'll break it down into both schizophrenia and those affective disorders. So schizophrenia, serious mental illness, it affects about 1/4 to 0.64% of adults in the US. So not a big span, but significant. This disease causes challenges in a person's ability to manage emotions, make decisions, and relate to others. So it's affecting all aspects of their lives. Ooh, Jack is back. Oh, then she's gone. Okay. The average age of onset is early 20s for men, late 20s to early 30s for women. They are doing some pretty interesting research right now about the onset of schizophrenia and hormonal changes. That's hormonal changes having this effect chemically in the brain, and what that looks like, and how we're seeing the onset of these with biophysical markers. And of course, schizophrenia is a long-term condition. This does usually progress and maintain throughout a person's lifespan. When we look at schizophrenia, we often see early warning signs in our teenagers. Things like changes in social behavior, a sleep disturbance, either sleeping too much or too little, withdrawal from family, friends, preferred interests, and an increase in unusual thoughts or suspicions. However, some of you can see nodding, right? That's very normal teenage behavior. So teasing apart what is your average teenager testing boundaries, trying new things, pushing away from what they already have done, having hormones and having changes in their body, and determining what's actually a mental health concern can be a little bit of a challenge in those early days. But we want to have kind of an awareness of that. The other piece of this is when we diagnose this early is whether or not a family member has a mental health concern in this area, whether it's schizophrenia or a severe mood disorder. Sometimes that's a flag for us as well. Then we can look at our affective or mood disorders, that other half of this disorder. So there are general emotional states that are distorted or not incongruous, not in balance, not reflective of the circumstances around the person, right? Your mood doesn't match what's happening. And these also interfere with your ability to complete daily tasks. You've got schizophrenia, and then you've got your mood disorder, and now you're doubly having to struggle getting through your daily. So the amount of mood disorders is a pretty endless list. Don't have to tell you all that. But I figured we'd hit some of the big ones. So major depressive disorder, right? A significant prolonged depressive period. Bipolar disorder marked by severe spikes and drops in mood, right? Depressive and manic episodes. Seasonal affective disorder, right? Depressive episodes that occur when there is less light in your hemisphere. Some of us may feel that, right, as we turn to the change towards winter. Psychothymic, has anybody ever heard of psychothymic disorder? I see a couple patients with this every once in a while. Very interesting stuff. So cyclothymic disorder, right? Cycles of mood disorders basically looks like little waves. So as opposed to bipolar that looks up and down, cyclothymic comes here. So you have this, little periods of depression that aren't as severe, followed by peaks of agitation and irritability, but not the full manic period. So it's pretty interesting. And then depression related to a medical illness, or and also depression related to substance use disorder. So these mood disorders obviously can express themselves in lots of different ways. So we're gonna just pause on the characteristics and the symptomology. I want to share a little history with you about schizoaffective disorder, because knowing this background and history kind of gives insight to where we are today with schizoaffective disorder. The first time we see schizoaffective in the literature comes to us in 1933 with Jacob Castanen. I can never pronounce it. He coins this term schizoaffective psychosis because he's starting to see patients with these mood presentations and also with these schizophrenic presentations as well. So he's going, what's going on here? Why do they have both? And they're both prolonged. So something's going on. Then in the DSM and the DSM-2, they say, oh, well, it's just got to be a subcategory of schizophrenia. Just schizophrenia plus mood. Oh, all right. In the DSM-3, they're like, no, there's enough instances of this disorder. It's got to be its own thing, but there's not enough of it for it to be really its own classification. So we're going to call it a psychotic disorder, not otherwise classified. It's not really schizophrenia. It's not really its own thing. It's somewhere, we don't know what it is. We're not going to specify. By the third revision, they do in fact make schizoaffective disorder its own illness. And they start to specify. They say you need to have a mood symptom that is overly depressed or severely manic for it to count as schizoaffective disorder. DSM-4, they're not doing a lot of research. They're not doing a lot of tracking until about this time. But by the time we get to the DSM-4, the criteria is so poorly written and so all over the place that practitioners are using schizoaffective disorder way too much. It's way overdiagnosed and it's not stable diagnosis. So what you find is somebody will come into the hospital, the provider will be like, oh, they've got psychosis with mood symptoms, it's schizoaffective disorder. Then they go to their outpatient provider and they're like, I don't know, no, it was a one-time incidence of depression, it's just schizophrenia. And then they come back and they find a different diagnosis, maybe it's bipolar. It's not stable, people aren't holding on to this diagnosis. DSM-5 is where we start to see the writers of the DSM really do some introspection. I don't think they quite nailed it, but they had some reflection. And what they tell us is that we've started to do this research. We're trying to tease apart, is schizoaffective its own thing? Is it part of schizophrenia? Don't know. So thank you for telling us you don't know. And what they have basically determined at this point is that it's not enough of its own illness for it to have its own diagnosis. And diagnosing it as such doesn't really help with treatment, right? You're not, essentially the treatment for schizophrenia and schizoaffective disorder look so similar that diagnosing schizoaffective disorder doesn't always make sense prognostically. However, that all being said, they still leave it in the DSM. And what they have basically said at this point is we need to do more thorough and long-lasting research with these populations to figure out what's going on. So that has been started. I wouldn't say it's super robust at this point, but it is moving forward. If I could hazard a guess from the couple of articles that I started teasing into that are more recent, 2020, 2021, my guess is that we're going to start seeing a spectrum, much like we see like Asperger's and autism on a spectrum. I think we're going to start seeing a schizoaffective, schizophrenic spectrum of disease. That's just, don't quote me on that. It's only speculation. Okay. So we don't know a lot, right? The history tells us that it's kind of all over the place. It's not really clear that researchers know exactly what's going on. But here's what we do know. There is a genetic component of some variety. We haven't teased out exactly what it is yet. But if you have a first-degree relative, a parent, a sibling with schizoaffective disorder or schizophrenia, you are more likely to also have it yourself. There's physiological components. So there are changes and abnormalities in your neurotransmitters. Your dopamine, your norepinephrine, and your serotonin levels are not quite what everybody else in the general population are. There's also white matter changes. They've been doing a lot of MRIs. You can see that people who have schizoaffective disorders, but they have different changes in the white matter in their brain that don't match contrasting comparison data. There's a reduced size in your hippocampus where learning and memory occur. Thank you. And there are also changes in your thalamic regions where you process sensory information, which makes sense, right? So if you have a person who's having an issue with sensory processing, which we'll talk about in a little bit, and those changes in the brain are being found. Trauma, social factors, and stress exacerbate things, right? So if you have had a traumatic experience, are going through a particularly stressful time in your life, or have other social factors, that's going to exacerbate your symptomology.
Question.
Sure.
I think you covered it, but I'm not sure. I know it can be diagnosed in young people. What is the average age of that you see of symptoms happening?
Specifically for schizoaffective disorder, we'll get there.
Okay.
People in who have schizophrenia, it's 20s for men, 20s to 30s for women.
Okay.
So let's look at what we do know about the population here. We're here. We made it. About 0.3% of the population has schizoaffective disorder. Right smack dab in the middle of that schizophrenia number. Schizoaffective disorder occurs more frequently in women. About 30% of cases present in 25 to 30-year-olds, which is not a huge number, right? That's only a third of the population. And it accounts for about 10 to 30% of inpatient hospitalizations in psychiatric centers. So despite the fact that we're only seeing it 0.3% of the population, it is accounting for a significant amount of people that we're seeing when hospitalized. So let's really dive into schizoaffective disorder itself. This is an uninterrupted period of illness. It includes both a mood episode and the characteristics of schizophrenia, right? So you need to have both pieces. So has to have schizophrenia, and this includes hallucinations and delusions for 2 or more weeks without a major mood episode. So you have to have alone hallucinations and delusions without a period of depression or mania. Symptoms of major mood episode occur for most of the total period of both active and residual persistence. So that being said, the mood disorder also needs to be prolonged. And this is not a result of the effects of substance or any other medical condition, right? We have to rule out all of those other things like delirium. So there are 2 types. The bipolar type includes both episodes of mania and managed depression, and the depressive type only. Carolyn. So our symptoms of schizophrenia, and please, anybody who works with this population, chime in, include delusions, false beliefs with no basis in reality. My food is poison. You have stolen my family. Hallucinations. These can be auditory, visual, and also all of your 5 senses. So I once had a person on my unit who hallucinated the smell of strawberries. Swore that there were strawberries in the room. Yeah, I was really happy that it was a really pleasant hallucination. Not all of them are. Perception of a sensation not present. Disorganized speech. Grossly disorganized or catatonic behavior. So I'm going to stand up, I'm going to sit down. Stand up, I'm going to sit down. I'm going to read my journal. I'm going to have lunch. Or I'm going to sit in my chair and I'm going to and a diminished emotional expression or apparition. So very flat, maybe not a full catatonic state, right? But very flat affect, monosyllabic, no interest in preferred activities. This person is not coming to groups. They are not doing independent activities.
I have a patient right now, and she kind of goes across the board. 1 minute she'll be calling me Queen Elizabeth. The next she'll be calling me some foul names. She just goes up and down, and there has been periods, not this mission, but previous ones, where she was catatonic before.
Yeah, patients can express, patients are individual, so their symptoms are going to express individually, and sometimes they express differently from admission to admission if you see people more than once. So our symptoms of mania: agitation, your agitation and your inability, stay away from me, I want to talk to you, go away. Inability to attend. So these are people who want to come to group sometimes because they're really excited about group, but they can be in the room for maybe 2-3 minutes and then they gotta go to, and then they'll come back. Maybe then they need to go and do something else. They're hyperverbal. They're going to talk really, really fast and they want to tell you everything all at once. And it's going to be really hard to follow them because sometimes they're here and then sometimes they're over there. Increased activity. Patients with schizoaffective disorder, I often make sure that the first thing they get is an activity notebook, a journal, and a magazine. They have an inflated sense of self or grandiosity. I had a patient with schizoaffective disorder once. She was amazing, amazing woman, but she believed that she was the queen of Hawaii. And she wanted all of, if she saw that you had a ring on her on your hand, she wanted it. The queen got the rings. It was really poor sleep. Right when you are in a manic state, your mind is racing. You can't turn off. Racing thoughts and disinhibition. Right? People in a manic state might do a lot of possibly drinking, possibly shopping, driving really fast. Specifically, I work with the older population, right? So these people will often stand up and go. No forethought for fall safety. So our symptoms of depression on the flip side, feelings of worthlessness, hopelessness, particularly in the elderly, we see depression as guilt. A lot of folks, as they age, will have a lot of regrets and they will tell us a lot of feelings of guilt that they weren't very nice to their family, or they didn't do the things that they wanted to, or they should have given more money to charity, those kinds of things. Low self-esteem, lack of energy, a change in appetite, whether for eating more or eating less, changes in sleep, loss of interest in hobbies, also trouble attending, weight changes, and pretty good chunk of the time, thought or action of self-harm. It's when we're in this place, we need to keep our eyeballs on our patients in the manic state pretty closely for safety. Sometimes our patients with depression are a little bit quieter. Okay, so let's talk about Barbara. Obviously, Barbara's name has been changed, and some of the characteristics about Barbara have also been altered just to protect her identity. Barbara, when she came to us, was 52 years old. She came to our emergency room with worsening symptoms. She came in with plan to commit suicide. And when she first admitted, she was hysterically crying in one moment and then laughing maybe 30 seconds later. She has been living in a skilled nursing home due to the level of assistance for activities of daily living. So she would often be able to get dressed and be able to get herself to groups, but wouldn't want to because she was feeling very depressed. She needed a lot of assistance with hygiene care, making sure that she maintained that dignity and that quality of life for herself. Staff at her skilled nursing facility could not identify a trigger for her decompensation and were pretty confused. She had been admitted to us a couple of times, and the last few times there were no triggers. She had lost a family member. This time she wasn't really sure what was going on that triggered that instance. Barbara, history of multiple hospitalizations due to recurrent. When she came to us, she was pretty certain that we were poisoning her food and that her medications were going to kill her. On our unit, she endorsed passive suicidal ideation. We always ask our patients twice a day, are you feeling suicidal? If you closed your eyes, are you looking to close your eyes and not wake up? And Barbara would tell us yes. However, Barbara was contracting for she would tell us, nope, don't have a plan. I'm gonna go to group. That's my safety plan. I'm going to group. And if I have a problem, I'm gonna tell staff. And she had incredibly poor insight and judgment. She did not believe that she had any kind of illness. Nope, it's you people. You're trying to kill me. And she had no safety awareness whatsoever. When Barbara first got to us, she would leap out of her chair without any warning and run down the hallway, which is very scary for us because Barbara had recently, in the last 6 months, had both hips replaced. And I think she wanted to give me a heart attack. And then when she would come, she had lots of periods of being tearful, couldn't tell us why. And then she'd come back to group and she'd be laughing very often. Barbara did eventually stabilize with us, and we don't have a lot of contact. We have a skilled nursing facility across the street from us. Where she went is not across the street, so I'm not sure how she's doing that. She was able to stabilize and participate in therapies, and I'm really hoping that Barbara's doing well. But she is a very classic case when we get on of somebody with schizoaffective disorder. Okay, so something I just want to point out here from the literature. We did a recent study of patients diagnosed with schizophrenia and people diagnosed with schizoaffective disorder. And there's this interesting parallel where both people with each disorder are found to have a cognitive performance deficit, right? They're not performing as well on cognitive testing as the normal population. And then they also have these structural brain deficiencies that you don't see on other evidence. However, only those folks diagnosed with schizoaffective disorder had greater emotional regulation skills. They were able to regulate these emotions more quickly. Right. I think it's pretty interesting, and I think bears witness to this possibility of spectrum. Okay. Okay. So I want to take a couple minutes here to think about, as we are, as practitioners, what we can do to think about treatment of these folks. So they come with history of trauma, either prior to their illness or as a result of things that have occurred while they are ill. They have lots of interpersonal conflicts. People with schizoaffective disorder who come to my facility usually have one family member or no family members. The last couple of patients I've had actually really broke my heart. They had family in the community that they knew lived locally, and they wanted nothing to do with it. So no, I've been helping for years. I can't do this. Folks with schizoaffective disorder generally deal with either cyclical employment, right, where they keep a job for a little while and then they can't have a job. They keep a job for a little while, they can't keep a job, or because of their illness or on disability. Substance use concerns, right? These folks are trying to self-medicate in any way that they can. They go to substance use, alcohol, drugs, etc. Because of their illness, they sometimes get manipulated into doing these things as well. They have a lot of health concerns beyond their mental health illness. They're not coming for treatment for schizoaffective disorder often, unless they have really good support systems in place. They're definitely not going to their other providers. So we see folks with lots of skin related issues because they're having a hard time maintaining hygiene and ADLs. We also see folks with, for the same reason, with lots of podiatric issues, long fingernails, long fingernails, dentition, and then a lot of other medical comorbidities, accessing those providers. Probably in part, right, because all of this works together. They're unemployed, they may not have health insurance, they might not be able to afford these services or know how to get a hold of them. poverty and homelessness, right? And then suicide attempts. Okay, Robin, I think you're starting to cook us.
Okay, go.
Okay.
Something goes. It goes back when you get
Just
full.
like, oh, here. So as we start to think about how to really effectively treat these folks, not only does their symptomology and how they present with hallucinations, delusions, mood concerns, but also all of their psychosocial considerations need to be in the background. So I'm going to stop yakking. If you three kind of want to work together for a little bit and you three kind of want to work together as a team, that'd be great. What we're going to do is just for a couple of minutes here, I want you to think about possible interventions in each of the 6 functional domains. I used 5, I think I yanked leisure. In each of these 5 domains that you might be able to try with folks now that you know enough about them that we can kind of start working on interventions. All right, so I'll stop talking, you guys work together.
Okay. No, I'm gonna do this. All right. So.
Is it Barbara or is it anybody?
Anybody,
We have to get our person in.
you can if you'd like. If it helps you frame your person out, that would be fine.
Yes.
You certainly can, yes.
What's our name gonna be?
How are we gonna fire?
Shane, what do you got? First name that comes to mind right now.
Steve.
Steve.
Great name, sure.
Why
Physical.
It's okay if you just come and sit in the group. You don't have to follow the movements. That's exercise. So for
So any
social
kind of exercise, like.
I encourage them to come over. They do,
Yeah.
they don't. They, some just sit, sometimes they say they're just gonna sit and then see what the activity is. And they really want to participate. Yeah, I think for social, that's what y'all, because when they're not in that. They.
Or even like a straight to the summer, right?
Only activity. Yeah. 2 weeks ago, we just played, the only place we played was 1 week ago, we are back in March.
Really?
Play golf with the game. Won't take any prizes. Yeah, I think for social.
That can be
She is. Feeling.
Yeah. And I have never.
Yeah. I would do some sort of that allows them to express themselves. So some sort of journaling, and I have to give them direction.
He's here, but he's, you know, just.
Color. So, the support group, the patient that I talked about earlier, she's an amazing artist. There's times when, right, this edition, she hasn't been drawing as much or right now, it's hard to tell. Mostly a manifestation.
I'm not the first question.
But, yeah.
For that emotional side, I have different. Maybe it's stuff around.
Yeah.
And then she can do on her own.
Yeah. Yeah, like for Christmas, we do
Do,
chocolate pencils.
Creative, right?
All kinds of stuff. Anywhere from a month to life.
Yeah,
Yeah, we're doing it for 3 days.
That's what our rendering is, right? So, and I'm so there.
Poetry,
Stay right.
Yes, the emotional.
Emotional is also.
Alright, so what's the final one for your motion?
That's created that has. True.
But I just find that would be like to do, I would like to know what I could do to do like, right, so it'd be some.
Yeah.
Social.
Well, party.
Two rooms a day.
Bring social. But I mean, if you go the other
Oh my God, yeah. I'm lucky if I can get 100 out of the state.
And then as soon as someone gets ended, I'm back in for health.
No, just
So they go. Right. Yeah, that's. I used to work with a
I mean, you actually need them when you're in ads. You can't be like,
Yes.
no, your mother is,
That was,
you know what I mean?
but at the same time, you're expecting them to, they should have to be functioning on how. True, ready to stand.
Yes.
That's because they saw. Right, so like how do we? We are.
Yeah. Maybe just reality based.
Yeah, she would want to work like her. She had on those.
With meeting them where they're at, but also.
She would like, she wouldn't do certain things because she said her meetings.
The reality.
Which she had to, you know, but she
All
wouldn't
the time.
disclose stuff either, like she was she's not being asked like questions like about what she did and like
Love journaling.
it was, she was yeah, that's exactly what she would say. It was challenging. But yeah. Yeah. We would ask. You know, do not ask me.
Mm-mm. I'm not talking. I don't know.
So there's,
She would talk normally while we were stage, that he would come up and say, oh, that's Stitch.
you know, if they want to buy.
It's like, that's great.
Yeah, exactly. Or if they want a Bible, the Bible's available.
All right. So we'll bring it back together here for a little bit. Tell me about, so of course, when we are talking, I know I actually heard this group name their person because it's person-centered care. So we need to have a person, right? So they had Steve, which I love. I love that you had Steve.
I didn't pick it.
Shane picked a great name. I think it's a perfectly suitable name.
He's laughing.
Oh, yeah. Oh, oh goodness. So, yeah, right. Of course, what I first want to forefront this conversation with is, of course, we are rec therapists. We're going to do an API process for this person. We're going to start with assessments. We're going to individualize this to their interests and hobbies, etc. This conversation, we're just going to create a general fund of knowledge for ourselves and, you know, shoot around some ideas so that you have these things. I call it, going to be really nerdy. Do y'all remember with the Adam West Batman?
Yeah.
That really lovely tool belt.
Yeah.
I call it the Adam West tool belt of skills. Work with people who are a little older, watched Adam West all the time. So when we do coping skills group, we'll say, what are you gonna take out of your tool belt today? And they're like, who are you and why are you being this nerdy?
I teach rugby and I literally brought a toolbox and had to sit down with my girls and we took things out of the toolbox and they were even experts on tools that they had in the toolbox because they thought they weren't.
Oh,
And so they were learning tools in the toolbox.
that's really
So
cool.
then they had to do experts on it.
I love a metaphor. I love a metaphor. So physical interventions that you all came up with. What do you think? What are we doing physically for our folks?
So for Steve, he had him on a walking group, sitting in walking, or a strength
Okay, awesome.
training.
I know, I do so sorry.
So walking and strength training for Steve.
Walking and strength training, fabulous. Small group, big group, one-to-one.
Depended on his schedule.
Yeah. A lot of just like all of our folks, but particularly these folks, need you to be able to adapt. You gotta kind of meet them where they're at, right? You don't know, some days, I have one gentleman who's with us right now, and every day is a different day. Some days he wakes up and he says, good morning, Mary, let's do it. And other days he wakes up and says, no, I'm gonna hurt the world today, I need to stay in bed. You know, to be willing to, adapt and make the right. So what did you all talk about for physical interest?
So we talked about an exercise group, a stretching group. I also put down a dance group and walk thing,
Cool, I like
which
it.
is like a walking group where I work.
No, all right. A walking group, I like it. Stretching group, cool.
I was thinking about the patient I had mentioned previously. And so she doesn't really attend groups so much, but she'll be out in the hall when I have music on and she'll start dancing.
Perfect. I love that. Yeah. Some of our folks that I've had with this disability don't want to be in the main milieu.
Yeah.
They don't want to be with everybody else. Yeah, a lot of times people will hang in the hallway. Right, they'll do some passive participation or some quiet engagement that you got to really pay attention to, right? Yeah, playing music in the hallway, making sure people are around and engaged. Love that. How about psychological and emotional interventions?
We talked a lot about this would be something along with the test driven and that match something that they like to do. So the patient that she was talking about used to draw a lot, was amazing at it. This time around hasn't been doing that. We're giving her a really task driven thing that we know that she can do. Just forcing her to have that alone time by herself and going out and finishing product. So it's not something aren't forced to be around.
Yeah, I think that's wonderful. I think breaking activity down and making it so that you can be fairly certain that be successful. So you can build on that success is something you really like that. So if they, upon discharge the last time they were with you all, they were painting oil paintings, and now they've come back and they're in a decompensated state, you might want to be sensitive to the fact that they're not going to be ready to do that right away, and providing maybe one sheet of paper and having them pick 2 or 3 colors and not what like obviously my first thought is crayons or crayons, right? Sorry, and providing that scaffolding approach of how much support they're going to need, right? They might need you to set up and supervise and get them going. What did you all think? Orlando, you're doing great.
Oh, we talked maybe a little more about just knowing triggers. Signs.
Poetry group. Yes. Anybody do a poetry group? Right.
We would read poets like.
Hmm,
I know, right? But
great choice.
I didn't. Right, based on that.
Okay. Hey, art is art. I don't yell at other people's young, or at least I try not to. Yeah, so we used to do this really stream of consciousness poetry group. And it can be broken down into a one-to-one. I did it for leisure ed, but it can be adapted to where you ask somebody what their favorite activity is. And then you use your five senses to create, it can be a haiku, it can just be a strange, funky poem. So, right, if it's like being outside or hiking, say, what types of things do you see? Oh, the grass, a dog, birds, great. What things do you smell? And it becomes this poem. And the fun thing about this activity is that you don't have to be a poet to do it. And they 98% of the time came out beautiful with minimal needing for artistry and poetry skills ahead of time. I think that's an almost no activity. If I'm not mistaken. That's finders. Cognitive.
Cognitive, you said, maybe, a book club, or even journaling, I don't know.
I'm sensing a lot of journaling, and I like that. Like I said, with people with this, everybody on my unit generally, if you are cognitively able to write, it's a journal and same with pencil, right? Or encourage that journaling. It's a good way to put some of those thoughts into out of your body and into something else, right? Particularly if you're in an environment. But I have found that it's particularly good for these folks because they have those thoughts. Sometimes when the intrusive thoughts can be harmful. Cognitive.
Something not in the creative writing.
Yeah. Yeah, write that down for group terminology when you write it in your note. Yeah, you've got, hey, Steve is a whole well-rounded person and his needs are going to be really important to me all the way around. All right, socially, how are we helping Steve?
Well, we said, like, we got a bunch of holidays coming up, so holiday event celebration. I was thinking about I have a bunch of mentally ill residents up in therapy, and we normally do like an Easter egg hunt where they have to help each other to figure out where to think about stuff.
Yeah. Anytime you can create space for people to be cooperative is awesome, especially if you're building this adaptation for people to challenge. I call it challenge by choice, right? Engage as much as you're able with the supports that you're provided.
What was that title one more time?
The creative writing group
Oh.
for
Symptom management. Symptom management for creative writing.
thank you. It's gonna be popping up in all of right. What did you all talk about socially?
We talked about just really encouraging them to groups, because a lot of people that are struggling pretty hard to really be around a lot of people, they've kind of isolate themselves knowing that they are feeling differently than everybody else. They've just chosen not to be around others. And so just encouraging them to group, whether or not they choose to stay with the time or engage, giving them credit for just simply being there and making sure that we acknowledge that they were there.
Totally. And setting up support for whatever level that they can be there, right? So I know because my program is military-based, most of our folks are in the day room all day long, and that's too many people when you first come on the unit and you are having an active episode, right? So we set up a smaller TV space for folks so that they can still socialize, but there's only like max 3 people in that space at any one time. And then we also have a hallway, which sounds really cold and personal, but it's actually like a much more low stimulation environment where people can choose to socialize if they choose to, but also can be quiet and have independent time. So there's a balance of 3 different spaces going on at once for that socialization option. Any other thoughts about socialization? Cool. All right, last one, spiritual. How are we spiritually helping Steve and or any of our other patients?
They're like analyzing their.
Ooh, okay, tell me more.
So some staff that we work with play music and the patient had to analyze it, and of course you pick something out of this spiritual base and discussion.
Perfect. Yeah, and spiritual runs the gamut, right? Like I once had a patient who was like, Dolly Parton is my religion. I'm like, okay, cool. I love Dolly. Let's go with it. She's got some awesome songs. We can figure out how to make this really spiritually connected. Cool. Coat of many colors. I'm on it. Let's do it. Right? Right. And that's all. I'm very jealous. I don't play an instrument at all. None of my staff play an instrument. So that the fact that you have musically talented folks with you is okay. Spiritually from this side.
So, we said, the option would, to go to, spiritual groups or a mass. Reading the Bible, having, a rosary. I've also done, I didn't just talk about, I've done like, a spiritual quotes group where like we come up with like some of our favorite quotes, or I read some aloud and they can put their favorite one of the day to consider.
Yeah, definitely. I will say sometimes in our Bible, which is extremely for someone, it's awesome.
Yeah.
Safety perspective. We have an Old Testament and a New Testament in English, Spanish, and applications words without speaking. So we've got. The other thing is, I also just have to get.
Well, you gotta be careful, right? Because then we do get the
Yeah.
True.
Yes.
Very true.
Yeah. Right. And so you do have folks who are going to persevere on these, right? And making sure that you're not feeding into that in a way that's so their recovery is really important. Yeah. That's where, right, using your team comes in handy and knowing when to validate and when to encourage reality orientation. And that's going to be a fine line as individuals for patients and to each of their journeys as they compensate. What else was I going to say about spirituality? Oh, the iPad is a beautiful thing. Use your technology. On every single one of our iPads is a Quran, a Torah, 2 versions of the Bible, and of course YouTube, right? Use YouTube. A lot of churches, even more so now because of COVID, have their services online. So I have had patients who can anonymously go and watch their church service live from YouTube. What better way to connect them socially to their community right then? And there's no video camera, so it's not as long as your IT team has figured out how to convert to that end. Any other thoughts? I think people where they're at. Yeah. So many thoughts. Yeah.
You also said meditation.
Yeah. Oh, speaking of, yeah, right? Mindfulness, meditation.
I say too, I used to work in that in mandala group. That's spiritual based and drawing.
Yeah. Mandalas are, that's an awesome mindfulness activity. All of the circles. coloring, mindfulness, and then lots of different types of breathing techniques that we have to do. So we touched a lot about this, community-based, when you can, within the person's own community, setting up those social supports, right? Making sure people are ready to be socially engaged in the communities of discharge, helping people to balance those sleep-wake cycles. That's usually a massive problem. And us doing those exercise groups, engaging people in the million throughout the day, keeping them awake and engaged, hugely beneficial. Stress reduction, mindful.
With that, I think it's like important to pass on to like the direct care staff for the off shifts, the engagement and stuff that we've been doing with them during the day to help with that sleep cycle, right? We're not there to eat for most of us, right? That's the time I think really the most. Just learning to, utilize the staff that you have, if you can grab some direct care that that are good and that you can, kind of do that.
Yeah, absolutely. And sometimes, at least in places that I've worked, we communicate that they need to be awake during the day. And then we don't, that's the end of the sentence. Right? They need to be awake. Okay, that's great. What would you like me to do with them? Right, let's communicate, let's use our resources. I'm sure each of you can identify one other staff member off shift. It's like, yes. Wellness planning, right? Helping folks identify ways to stay well. All of those different domains, helping them upon discharge to set up resources for wellness. All right, so here's Barbara. She's back. So when Barbara was with us, we encouraged her to attend groups, and we created a schedule just for her. She needed a visual to maintain attention to task. So when Barbara would wake up, she would check it off the list. I woke up, I got dressed, I had breakfast. Cool. Now I know the next thing that I'm going to do is go to group. Then when Barbara would be in group, she would be in group for as long as she could maintain group. She needed to go. There was a staff, because she was actively suicidal upon admission. She was line of sight 1-to-1 for the first week or so that she was with us. And so they would take her for a walk in the hall, reroute some physical energy, do some stretching and some exercise in the hallway. And then she would come back to group and attend tasks for as long as she could, until we built her up into being able to be at an entire group for the entire period of time. When Barbara came into our milieu, she did not get to sit dead center in the middle of the group room. That is too activating. Barbara, if she would sit in the middle of the milieu, would probably start to cry right off the bat. Too much stimulation. So instead, Barbara sat next to the door, where not only was she not disruptive and she needed to get out of the room, but she could also get out. We helped her identify her preferred interests and to engage in them. So we gave her, first, a recreation assessment, and then we wrote them down and gave her a visual aid. She got a journal, she got a coloring book, and we helped to give her that attention to task completion, opportunity to be successful independently. And then she also completed stress management and mindfulness groups. We're really blessed. We have a massage therapist who comes 3 days a week to do massages in the morning for us. And that actually, my massage therapist is there are people in this world who are healers and who can do that work, and they are so amazing. Monica is a saint, and she actually built a really beautiful relationship with this woman. And so that was probably one of the more effective things, was having the stress management opportunity through massage therapy and the validation that the massage therapist was able to give her. So use that team. And between interventions and group therapy and obviously medications, she did in fact recompensate, and she went back to the skilled nursing facility at baseline when she was with us previously. Okay, that's me. Any final thoughts? We have an advanced group of practitioners here. Any other final thoughts, feelings about schizoaffective disorder? And with that, whew, that's good because I'm a minute behind. Sorry, everybody. Thank you.
Thank you. You have your emails, for the session, I'll take them back.